Hello, today we will deal with the treatment of pneumonia and especially patients in the hospital. So patients are coming from the community, outside the hospital. And they're coming to the doctor's office and he has to decide whether the patient will stay in the hospital or not. If not, then the patient is treated as an outpatient. And this treatment have been dealt in another video. So we can treat community patients at home. These are called outpatients. Or we can treat them in the hospital and we can divide them into in the ward or in the ICU, so intensive care unit. So in the hospital we can divide them into the ward or intensive care unit, depending on the severity of the case. And how do I decide? I decided with a scoring system called PSI, so Pneumonia Severity Index. And this score then will tell me now to either that I can send the patient home and treat it at home, or I can treat the patient in the hospital. And then I have to decide whether it's very severe, then I send the patient into ICU, so intensive care unit, or if it's not so severe, then I treat the patient in the ward. And this is called community-acquired pneumonia because it's acquired in the community. The patient got the pneumonia in the community and not in the hospital, because then we call it hospital-acquired. Because if the patient acquires it in the hospital itself, then it's called hospital-acquired. And another fancy name is nosocomial. 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 This is when the patient gets the pneumonia in the hospital itself. But today we are dealing with the treatment of these patients, okay, in the ward and in the ICU, who got it in the community. What is important to memorize or to learn is the PSI, the Pneumonia Severity Index. I have dealt with this in another video, and here this is a very good scoring system. It's better than any other scoring system in dividing the patients. So please learn this. What do we do next? The patient comes in and we have decided that the patient will stay in the hospital. We have to take something called procalcitonin in the beginning. Procalcitonin is a lab value that we can get from the lab, and this will show us the bacterial infection from the patient, especially bacterial infection. So if we draw a graph here and we take this procalcitonin level, let's say in the first day, and then we take it every 2 days, we repeat it serially, this test. So first day it was at this level, okay? Second day maybe it's increased. Third day, after 4 days, it's decreased. Before we leave the patient, so before we allow the patient to go home, this level has to be decreased, the procalcitonin, because this shows us how high the infection is, how high the bacterial infection is. And let's say we started to treat the patient here. Then we see that at the point where we started to treat the patient, it started to decrease, this infection started to decrease, and therefore it's important to get this procalcitonin in the beginning so we can compare it. Okay? What else do we need? Except for procalcitonin, something very good to take is sputum culture. And this also have to be taken before we give antibiotics. So you take a saliva from the patient and then we send it to the pathology lab, and in the sputum culture then they will list all the pathogens that can be found in the sputum. And for example, the most common one is Streptococcus pneumonia. This is the most common. Mycoplasma pneumonia is another one which is common. Mycoplasma pneumonia. These two are the most important, especially the first one, Streptococcus pneumonia. But we are also interested in some severe infections like MRSA or Pseudomonal. So MRSA and Pseudomonas are very dangerous. We also have Legionella. Legionella. These three are more dangerous ones, and they are very important to detect, so we can direct the treatment against these specifically. Because the broad spectrum antibiotics that we will give, broad spectrum just means that we give an antibiotic treatment that is very broad, and it will cover this Streptococcus and Mycoplasma pneumonia. These are the most common bacteria, and it will cover these. But if the patient have an MRSA or Pseudomonas, then we need to direct the treatment against these, because a broad spectrum will not help us to treat these, and therefore is very dangerous if we don't get this sputum culture in the beginning. So please, the patient comes in, we take a procalcitonin and we take a sputum culture. What do we do next? We do an X-ray. And I would say you should do that first, okay? You should take the X-ray first. This is the gold standard. So you get the picture, of the lung, and there you will see shadows of pneumonia, okay? And then we know that it's pneumonia, and then we can start with the treatment, broad spectrum treatment at first. So we start, this is called empiric treatment. That's the broad spectrum, and then we go on with specific. Because it takes time for the sputum culture. This takes time for us to get the results from the sputum. And therefore we start with empiric, and then when we have these specific pathogens listed by the pathology lab, then we can go on and treat these specifically. But until then, we did an X-ray. We saw that it's a pneumonia. We started empiric treatment, and then we waited for the sputum. And then when we have that day, when we have the specific, then we start to treat the specific ones. So we change these antibiotics to a more specific antibiotics. Good. Now, I need to divide patients. Now we go on to the hardcore medication, because this is a bit complex, and I will try to simplify it as much as possible. We have patients who are in the ward, and we have patients who are in the ICU, intensive care unit. Okay, let's start with the ward. I need to group the patients into those who have allergy to beta-lactams. This beta-lactam are, for example, penicillin, cephalosporin, and carbapenem. So I asked the patient, do you have any allergy against penicillin, cephalosporin, and carbapenem? If yes, then this patient have a beta-lactam allergy, which means that the treatment will be different. I cannot give penicillin, cephalosporin, or carbapenem to this patient. And that's important now. Most of the patient does not have any allergy. So that's a good sign. So I will start with no allergy. No, I will start with allergy. Let's see, I will start with allergy first. Allergy to beta-lactams. And then I need to divide the patients into those who have no pseudomonal or MRSA risk factors. So risk factor for pseudomonal infection or MRSA infection. These were the two dangerous infections that we talked about. So I write here pseudomonal. And then I have MRSA. So now I have divided the patient into those who are in the ward. They have an allergy to beta-lactams, and they have no risk factor for pseudomonal or MRSA. In these patients, I will give a levofloxacin. And what is levofloxacin? It's a fluoroquinolone. And this have a doses of 750 milligram per day. So once daily. And this just means that we give it in the morning, we give nothing in lunchtime and in the evening. So we give levofloxacin to patients who have no risk factors for pseudomonal or MRSA, and they have an allergy against beta-lactams. What do I do with pseudomonal? And this is in ward patients. So let's forget ICU for a moment. What do I do with pseudomonal? I also give levofloxacin. So I will give levofloxacin for all of these cases. For pseudomonal, I also give levofloxacin. And for MRSA patients also. Levofloxacin. But for pseudomonal, I need to add something. And this is called Astreonam. And I also need to add an aminoglycoside, which is, for example, gentamicin. So for pseudomonal, we have levofloxacin 750 milligram once daily. I have Astreonam, which is 2 gram every 8 hours, and gentamicin. So Astreonam you give 2 gram every 8 hours. Good. What do I give for MRSA patients? Here I need to add vancomycin. Okay? That is attacking MRSA. For pseudomonal, Astreonam and gentamicin is attacking pseudomonal. And for no pseudomonal and no MRSA, we have only levofloxacin. Okay? What about the case when we have pseudomonal and MRSA at the same time? Then we combine all of these, which means, what do we have here? We have levofloxacin, also here levofloxacin. We have Astreonam, here we have vancomycin. So let's put this here, and then we have levofloxacin, Astreonam, gentamicin, and vancomycin. This is when we have pseudomonal and MRSA, because then we attacked the MRSA with the vancomycin, and we attacked the pseudomonal with Astreonam and gentamicin. So that's what we have to put here then, when we have a combine. But I have not written a separate one here because I don't have space. So I have written then that you just need to combine these together with the vancomycin for when you have risk factor for both of these. Good. Let's talk about when we have no allergy. So I will write no allergy. Good. The same here. We have the same rows. MRSA, pseudomonal, and nothing. Here we will start with something called ampicillin. Ampicillin sulbactam. Ampicillin sulbactam is a beta-lactam. Here we can use the beta-lactams. We said we don't have any allergy against beta-lactams, and this is a beta-lactam. And we will use ampicillin sulbactam, which is 3 gram per day. And this means that we have 1, 1, 1. We have 3 gram 3 times daily. Okay? For pseudomonal, we will use another beta-lactam. It's called piperacillin. Piperacillin tazobactam. This is better against Pseudomonal than the ampicillin. So please don't use this beta-lactam, ampicillin sulbactam. Instead, use the piperacillin tazobactam against Pseudomonal. And together with a beta-lactam, we need to add an azithromycin. This is a macrolide. This is a macrolide. This is a beta-lactam. For Pseudomonal, we don't add a macrolide. Instead, we add a fluoroquinolone. We add a levofloxacin. The same as we had here. Levofloxacin 750 milligram. One times daily. For MRSA, we don't need this strong one, piperacillin tazobactam. We can give ampicillin sulbactam. That's more than enough. So we will give ampicillin sulbactam together with something that attacks MRSA, and that is, for example, vancomycin. Vancomycin. This one, the same here. So, this is with no allergy. So we added a beta-lactam, we added a macrolide for no risk factors for Pseudomonal or MRSA. For Pseudomonal, we needed to add the stronger one, piperacillin tazobactam, with a levofloxacin. With MRSA, we could give the same as here, ampicillin sulbactam. Now, if we want to combine Pseudomonal MRSA risk factors, as we did above, then we just combine all this again. And in this way, we have to attack the Pseudomonal, and we will do that with the piperacillin tazobactam. And we have to attack the MRSA, which we'll do with the vancomycin. So please put, for the combination of these two, put the vancomycin here, and then we have piperacillin tazobactam, levofloxacin, and vancomycin. But please note that we are not allowed to combine piperacillin tazobactam with vancomycin, because that can cause acute kidney injury. Acute kidney injury. So it's very dangerous. Don't combine vancomycin with piperacillin tazobactam. What do we do instead? The other drug that is good against MRSA is linezolid. Linezolid. So I will write it here. Linezolid. That is another drug that is good against MRSA. And linezolid and piperacillin tazobactam can be used together. Or I can use a vancomycin, but then I need to change this one, piperacillin tazobactam, because I'm not allowed to use these together. And another drug except this is cefepime. I will write it here. Cefepime. It's a cephalosporin instead of that. So I have two choices here. I can give a linezolid with piperacillin tazobactam, or I can give a vancomycin with cefepime. But I cannot give vancomycin with piperacillin tazobactam. We said that for no risk factors, we gave ampicillin sulbactam and azithromycin. Okay? We have to do the same here for MRSA. So not only vancomycin, we have to give exactly the same as we have here, but we add vancomycin. So we give azithromycin. We give azithromycin plus a vancomycin. So let's make a quick revision. We had patient who is in the ward, in the regular medical ward. The patient does have an allergy against beta-lactams, and the patient does not have any risk factor for Pseudomonas or MRSA. I give levofloxacin 750 milligram 1 per day. I have another patient who is in the ward. He have an allergy against beta-lactam, and he has Pseudomonal risk factors. I give the same levofloxacin 750 milligram 1 per day, but I also add Astreonam 2 gram every 8 hours, and an aminoglucoside, which is gentamicin, for example. So I had levofloxacin, aztreonam, and gentamicin for pseudomonal. I have another patient in the ward with allergy, with MRSA risk factor. I have the same levofloxacin. So all the patients with allergy against beta-lactams will get levofloxacin. That's one thing you can remember. Levofloxacin for all the patients. But the only difference is aztreonam, gentamicin for pseudomonal, and vancomycin for MRSA. And what do I do when I have a patient, another fourth patient, in the ward with allergy, with pseudomonal and MRSA risk factors, both of them? Then I do levofloxacin, aztreonam, gentamicin, plus a vancomycin. Then I have the whole 1, 2, 3, 4 medications for patients with pseudomonal and MRSA. Good. Now I have another case. In the ward, no allergy. This is the most of the cases. So I want you to remember this part mostly because this is the most common. A patient in the ward, a patient with no allergy against beta-lactams, so I can use beta-lactams. Then I will use ampicillin sulbactam, 3 grams 3 times daily. Ampicillin sulbactam, this is a beta-lactam, together with a macrolide, azithromycin. Another case, in the ward, with no allergy, but with pseudomonal risk factors. Instead of using ampicillin sulbactam, I will give piperacillin tazobactam, which is stronger against pseudomonal, pseudomonal, piperacillin. Remember the 2 P's, they're together. And I will use, instead of using a macrolide like I did here, azithromycin, I will instead use a levofloxacin. Levofloxacin. So a fluoroquinolone. That was for pseudomonal. I have another case, a patient in the ward, no allergy, with MRSA risk factors. I will give the same treatment as he got here, with the no risk factors, ampicillin sulbactam and azithromycin, ampicillin sulbactam and azithromycin, together with a vancomycin, because remember, vancomycin attacks MRSA. Good. And now the fourth case, in the ward, no allergy, and risk factors for both pseudomonal and MRSA. Then I give piperacillin tazobactam, levofloxacin, and I add a vancomycin, but don't add vancomycin here. Add instead the brother of the vancomycin, which is linezolid, because I'm not allowed to use vancomycin together with piperacillin tazobactam. So for pseudomonal MRSA together, I add all these, but I watch out to not give vancomycin together with piperacillin tazobactam. So I add instead linezolid, which is 600 milligram every 12 hours. Okay, vancomycin is 15 milligram per kilogram of patient. So if the patient is 70 kilogram, then I have 70 kilogram times 15, which is 105 milligram every 12 hours. That's vancomycin. For linezolid, it's 600 milligram for 12 hours. Good. And now, this was only in the ward. What about ICU? And now you will start to sweat. In the ICU, let's make it very, very simple. And we are really lucky that it's simple. And I'm lucky too, because I'm starting to sweat now, because this is kind of complex. In the ICU, we only add aztreonam. For example, we are in the ICU with allergy, with a patient with no risk factors for pseudomonal MRSA. We give levofloxacin as we did in the ward, but instead of only giving levofloxacin, we add an aztreonam. So I have drawn this kind of circle so you can remember that this is in the ICU. And please take note. When we're dealing with pseudomonal, we already have an aztreonam here. So we don't need to give another aztreonam. So this is exactly the same. Thank God. So we have a pseudomonal in the ICU, will get the same treatment in the ICU and in the ward. What about MRSA? Here we also need to add an aztreonam. Aztreonam. So as you see, what's the difference between ICU and ward? It's we add an Aztreonam everywhere, but since we already have an Aztreonam here, we don't need to add that. The treatment in the ward and in the ICU is exactly the same, and that's really, really good because this is the most common. So, to summarize, the most common type of patient is a patient who are not allergic to beta-lactams, not allergic, and we will treat this patient with no Pseudomonas MRSA risk factors, with ampicillin, sulbactam, and a macrolide, azithromycin. So beta-lactam with a macrolide. The same with MRSA, beta-lactam and a macrolide, but we add a vancomycin. For Pseudomonas, it's not ampicillin, sulbactam, it's instead piperacillin, tazobactam, because this is against Pseudomonas, with a fluoroquinolone instead, not macrolide, a fluoroquinolone, levofloxacin, and when we have a combination with Pseudomonas MRSA, then we add a linezolid with piperacillin, tazobactam, or we can use vancomycin, but then we have to change this one to cefepime. Cefepime. Good. And let's take the other patient who has an allergy. In the ward, no risk factors, then levofloxacin. That's it. In the ICU, you also add an Aztreonam. In the ward, for Pseudomonas, we have also levofloxacin, but then we add these two, Aztreonam and gentamicin. This is an aminoglycoside. In MRSA patients, we also have a levofloxacin, but we also added vancomycin. In the ICU, you also added an Aztreonam. So 3 Aztreonams here. And that's it. Thank you very much for listening.